At around 10 a.m. on June 20th, 2001, Rusty Yates received a phone call from his wife. He had been gone from the house for barely an hour. "You need to come home," Andrea said. Confused, Rusty asked what was wrong. "It's time," she told him. "I did it." Knowing Andrea had been struggling with severe depression, he pressed her. "What's going on?" "It's the children," she said calmly. That's when Rusty realized something was terribly wrong. "Which one?" he asked. "All of them." When Rusty arrived at their home in Houston just 15 minutes later, police cars and ambulances filled the street. According to Time magazine, when officers wouldn't let him inside, he ran to the back of the house screaming, "How could you do this?" before collapsing onto the lawn, pounding the ground as Andrea Yates was led away in handcuffs. Today, we're revisiting one of the most infamous and most misunderstood criminal cases in modern American history, the killing of 5 children by their mother, Andrea Yates. This case didn't just divide a jury. It split the country and exposed how unprepared the U.S. legal system and medical systems actually were, and arguably still are, to recognize and respond to severe maternal mental illness. I'm Brittany Ransom, and this is When Killers Get Caught, the podcast where we dig into the lives, behavior, and psychology behind the most extreme crimes and what happens after the truth comes out. I covered this case originally in 2021. I'm returning to it now to ask a harder question. What have we actually learned, and what hasn't changed at all? This episode contains in-depth discussions of infanticide, postpartum psychosis, suicide, and severe mental illness. Listener discretion is advised. Andrea P. Kennedy was born on July 2nd, 1964 in Hallsville, Texas, the youngest of 5 children in a deeply religious Catholic family. From the outside, her upbringing appeared stable and conventional. Her parents emphasized faith, discipline, modesty, and achievement, values that shaped Andrea's identity from an early age. Emotional restraint was encouraged. Personal suffering was not openly discussed. Mental illness, when it appeared at all, was often interpreted through a moral or spiritual lens rather than a medical one. Andrea learned early how to perform excellence. She was an exceptional student, consistently earning her top grades and praise from teachers. She graduated as the valedictorian of her high school class and was inducted into the National Honor Society. Educators described her as intelligent, reserved, and intensely driven. She was not a troublemaker, not outspoken, not rebellious. Andrea followed rules. She met expectations. She internalized the idea that worth came from achievement and self-control. What few people recognized at the time was that Andrea's inner world did not match her outer world. As a teenager, Andrea developed bulimia, a very serious eating disorder marked by a cycle of binging, purging, and intense shame. Eating disorders are often rooted in a need for control, particularly in environments where emotional expression is restricted. Andrea's struggle remained largely hidden, as these illnesses often do. She experienced persistent depression and recurring thoughts of suicide, and at 17 years old, she seriously considered ending her life. There was no indication that Andrea received sustained psychiatric care during her adolescence. In the cultural context of the time, particularly within conservative religious households, mental health struggles were frequently minimized or framed as phases, weaknesses, or spiritual shortcomings. Andrea learned to suppress distress and continue performing. After graduating from high school, Andrea enrolled at the University of Houston, where she pursued a degree in nursing. The profession appealed to her sense of duty and structure. She excelled academically, earning her nursing credentials and entering a demanding field that required emotional endurance. Andrea eventually secured a position at MD Anderson Cancer Center, one of the most prestigious oncology hospitals in the country. For nearly 10 years, she worked with patients facing terminal illness. The job required constant exposure to suffering, grief, and death. Colleagues described Andrea as competent, calm, and meticulous. Patients found her reassuring, but the emotional toll, it was significant. Working in oncology is associated with very high rates of burnout and depression, even among people without prior mental health vulnerabilities. Andrea carried her own unresolved depression into an environment saturated with mortality. She continued to function professionally, but there is evidence that her mental health continued to deteriorate beneath the surface. In 1989, Andrea met Rusty Yates, a NASA engineer who lived in her apartment complex. Rusty was intelligent, articulate, and deeply committed to his religious beliefs. The two began dating and moved in together fairly quickly, eventually marrying in 1993. From very early in their relationship, Andrea struggled with her issues relating to sexuality, intimacy, and self image. She was uncomfortable with her body and reportedly viewed sex as something religious, obligatory, rather than mutually expressive. Rusty attributed these struggles to Andrea's deep religious upbringing, but they were also consistent with her history of disordered eating, depression, and low self worth. What is critical to understand is that the nature of Rusty Yates' belief system and the degree that it would shape Andrea's life. See, Rusty embraced a rigid, fundamentalist interpretation of Christianity that emphasized male authority, female submission, and a strict separation from secular society. He believed that the modern woman and the modern world were morally corrupt. Children were especially vulnerable to spiritual contamination, and these beliefs were not peripheral to his life. They were central. After their marriage, Andrea's world became increasingly narrow. Rusty discouraged Andrea from continuing her nursing career, despite her years of training and experience. He expressed skepticism towards institutional education and advocated for homeschooling. The couple adopted an austere lifestyle and prioritized religious purity over comfort or social integration. At one point, they lived in a converted bus, further isolating the family from broader community support. Andrea had long relied on structure and external validation, lost key stabilizing elements of her identity. She was no longer a nurse. She was no longer a part of a professional community. Her role became almost exclusively defined by marriage, motherhood, and religious obedience. Between 1994 and 2000, Andrea gave birth to 5 children in rapid succession. Early pregnancy placed additional strain on her physical and psychological health. Postpartum depression emerged after multiple births and grew progressively more severe. Andrea became withdrawn, stopped eating properly, and struggled to care for herself. She expressed overwhelming guilt and feelings of inadequacy, frequently describing herself as a bad mother. Her religious environment amplified these fears. She internalized the belief that mothers bore full responsibility for their children's moral and spiritual outcomes. Any perceived failure, frustration, anger, exhaustion became evidence in her mind that she was fundamentally unfit. Rather than viewing motherhood as a shared responsibility, Andrea experienced it as a relentless spiritual test she was failing. And in 1999, Andrea attempted suicide again, this time overdosing on medication. She was hospitalized and formally diagnosed with severe depression. This event marked a critical escalation in her mental health crisis. Medical professionals warned Andrea should not have any more children, noting the extreme toll that pregnancy and postpartum hormonal shifts had taken on her psyche. Despite these warnings, she became pregnant again. Following the birth of her 5th child, her condition worsened dramatically. She experienced psychotic symptoms, including delusions, profound withdrawal, and near catatonic states. She became fixated on the themes of sin, punishment, and unworthiness. These beliefs were not abstract religious concepts. They were rigid, intrusive, and detached from reality. She was hospitalized multiple times and prescribed antipsychotic medications. At points, her symptoms improved. However, stabilization was often brief. She was repeatedly discharged back into the same home environment, one characterized by isolation, overwhelming responsibility, and religious absolutism. Her support system was limited. She had little autonomy, minimal social contact, and no sustained therapeutic continuity. Medical professionals emphasized the importance of strict medication adherence and constant supervision. But those safeguards were inconsistent in Andrea's life. By early 2001, her mental health had profoundly deteriorated. She stopped bathing regularly. She spoke very little. She stared blankly for long periods. She became increasingly disconnected from daily reality. Family members and clinicians alike observed she was not able to function independently. Andrea Yates' history before June 2001 is not one of sudden change. It is a slow, visible progression, decades of untreated or undertreated mental illness, compounded by isolation, repeated childbirth, and an environment that frames psychological distress as a moral failure. Understanding this history does not justify what occurred, but it does challenge the simplistic narratives that followed. Narratives that reduced Andrea to a caricature rather than acknowledging the complex, systemic failures that preceded her breakdown. She was not invisible before June 2001. The warning signs were present. Diagnoses were documented. The risks were known. They simply were not addressed in a way that could have altered this trajectory. To understand Andrea Yates' psychological collapse, it is essential to understand the belief system that dominated her adult life, not as a vague backdrop, but as a daily internalized framework through which she interpreted her worth, her body, and her children. See, Rusty Yates was a devoted father of the itinerant preacher Michael Warrenecki, a self-styled evangelist whose teachings blended fundamentalist Christianity with extreme interpretations of original sin, female culpability, and apocalyptic fear. Warrenecki's sermons were not casual expressions of faith. They were relentless moral indictments, built around the idea that humanity, and women in particular, were inherently corrupt and perpetually at risk of damnation. At the center of Warrenecki's theology was the doctrine of original sin, interpreted in its harshest possible form. According to his teachings, all humans were born tainted by sin, but women carried a unique burden. Eve's transgression in the Garden of Eden was not a symbolic story or a theological metaphor. It was a permanent moral stain passed down through every woman who had followed. Women were seen as spiritually defective by nature, more susceptible to evil, and uniquely responsible for leading others astray. In his worldview, motherhood was not nurturing or rational. In this worldview, motherhood was not nurturing or relational. It was a moral battleground. Women were held fully accountable for the spiritual fate of their children. If a child sinned, rebelled, or strayed from God, the failure was not shared with the father or attributed to human complexity. It belonged entirely to the mother. She had failed in her vigilance. She had allowed corruption to enter her home. This theology left no room for human imperfections. Normal maternal emotions, frustration, exhaustion, resentment, sadness, they were framed as evidence of moral rot. Mental illness was not a medical condition. It was a spiritual weakness. Depression was not suffering. It was selfishness. Doubt was rebellion, and silence was guilt. Andrea absorbed this belief system completely. Unlike Rusty, who approached the theology from an intellectual perspective, Andrea would internalize it emotionally. She did not treat Warrenecki's teachings as abstract doctrine. She treated them as if they were the literal truth. His words became the lens through which she evaluated every thought, every action, every perceived failure. Warrenecki maintained a direct relationship with the Yates family, communicating with them personally. He did not offer pastoral comfort. Instead, he reinforced Andrea's worst fears about herself. According to court records and correspondence, Warrenecki told Andrea explicitly she was evil, that she was spiritually defective, and that her very nature posed a threat to her children's salvation. These were not offhand remarks. They were repeated messages. Andrea was told if her children were sinful, it was because she had corrupted them. If they disobeyed, it was evidence of her failure. If she felt overwhelmed or disconnected, it meant Satan had a foothold in her soul. There was no separation between Andrea's internal suffering and the moral verdict that was placed upon it. The concept of female submission was equally central to Warrenecki's teachings. Women were expected to submit not only to God, but to their husbands as spiritual authorities. A wife's role was obedience, service, and silence. Questioning one's husband or one's preacher were framed as rebellion against God himself. For Andrea, this eliminated any internal checks against harm. If Rusty endorsed Warrenecki's theology, then resisting it meant defying both her husband and God. If a belief caused distress, the distress was not a sign to question the belief. It was proof she deserved this pain. This dynamic was particularly dangerous given Andrea's long history of depression, eating disorders, and suicidal ideation. Warrenecki's theology did not merely fail to accommodate mental illness, it actively weaponized it. Every symptom became evidence of spiritual corruption. The more Andrea struggled, the more guilty she felt. The more guilty she felt, the harder she tried to purify herself. And the harder she tried, the more she failed. It was a closed system. Apocalyptic fear was another defining feature of his teachings. Warrenecki preached that the world was descending rapidly into moral decay, and that children were especially vulnerable to damnation. Popular cultural public education, and secular society were portrayed as spiritual toxins. The only safe place was in the rigid boundaries of a godly home. And even then, danger would lurk if the mother faltered. For Andrea, this created a constant state of vigilance and dread. She did not experience motherhood as a relationship. She experienced it as a surveillance job. Every moment required monitoring for signs of sin, not only in her children, but herself. A fleeting angry thought became catastrophic. A moment of emotional numbness became proof of her damnation. After Andrea and Rusty married in 1993, these beliefs would move from theory into her daily practice. See, she quit her nursing immediately after the wedding. Her professional identity, financial independence, and connection to the outside world disappeared virtually overnight. She became pregnant right away, and from that point forward, her entire sense of worth was bound to her performance as a wife and mother under the terms of this theology. There was no theological allowance for rest, no concept of shared responsibility, no mercy for imperfection. The doctrine Andrea lived under demanded total purity while offering no mechanism for achieving it. Importantly, this belief system was not balanced by a broader church community. The Yates family was not embedded in a stable congregation with pastoral oversight and accountability or diverse perspectives. Instead, they followed this charismatic preacher whose authority went largely unchecked. His influence entered their home without the moderating structures that might have challenged or even softened these teachings in a normal church. There was no one telling her that illness was not a sin. No one telling her that mothers are just human beings. And no one telling her that God did not require perfection to offer his grace. The theology that followed Andrea home did not simply coexist with her mental illness, it amplified it, providing language for her despair, structure for her self-loathing, and moral justification for her fears. Over time, it eroded any remaining boundary between psychological suffering and spiritual condemnation. By the time Andrea's mental health began to visibly unravel, the belief system she lived under had already stripped away her ability to interpret that unraveling as a sign for help. In her mind, suffering did not mean she needed care. It meant she was failing God. After the birth of her first child in 1994, Andrea Yates began experiencing symptoms that would have triggered immediate and sustained psychiatric intervention. She reported violent, intrusive thoughts, sudden unwanted images of harm that terrified her. She experienced auditory hallucinations, including voices that condemned her and reinforced her sense of worthlessness. These symptoms were not fleeting. They were persistent, escalating, and deeply distressing for Andrea. But she told no one. Intrusive thoughts are one of the most misunderstood symptoms of severe perinatal mental illness. They are not desires or intentions. They are involuntary mental intrusions that cause intense fear and shame. For someone like Andrea, already living under theology that framed these thoughts as moral failings, these symptoms became unbearable to disclose. She believed that having the thoughts meant she was evil, not ill. And over the next 6 years, she would become pregnant 4 more times. Each pregnancy followed the same pattern: temporary functioning during her gestation period, followed by rapid psychological deterioration after birth, severe depression, withdrawal, disordered eating, obsessive guilt, and then increasingly psychosis. During trial testimony, psychiatrists described Andrea's condition as progressive and cumulative. Each episode left her more vulnerable to the next, and rather than recovering between pregnancies, she was stacking untreated trauma on top of an already compromised mental state. By the mid-1990s, Andrea's symptoms were no longer limited to depression. She was exhibiting classic signs of psychosis: fixed delusions, auditory hallucinations, impaired reality testing, and profound disorganization. She became rigid in her thinking, unable to tolerate any ambiguity or reassurance. Still, she continued to give birth. Trial experts emphasized that repeated pregnancies without recovery time dramatically increase the risk of postpartum psychosis, especially in patients with pre-existing mood disorders. Andrea had that history. She had struggled with bulimia, depression, suicidal ideation since adolescence. She had documented suicide attempts. These were not isolated episodes. They were early indicators of a chronic mood disorder, and it was going largely untreated. And in 1999, her illness reached a breaking point. That year, she attempted suicide 2 more times. In one attempt, overdosing on medication, and another, self-harm through violent means. She was hospitalized and placed on under psychiatric care, where she was diagnosed with major depressive disorder with psychotic features. Later evaluations, including testimony during her trial, clarified that Andrea's symptoms were consistent with postpartum psychosis, a rare but severe condition affecting approximately 0.1 to 0.2% of mothers giving birth. Postpartum psychosis is not postpartum depression, though. It's not the baby blues, it's not exhaustion or being overwhelmed. It is a psychiatric emergency. Patients experience hallucinations, delusions, severe mood instability, and a complete break from reality. Without treatment, the condition will worsen rapidly. With treatment, outcomes are often favorable. Antipsychotic medication, mood stabilizers, sleep restoration, and sustained monitoring are essential to getting better here. Andrea needed all of those things, and what she received was fragmented care. During those hospitalizations, Andrea would stabilize temporarily when she was placed on antipsychotic medication and removed from the environmental stressors. Medical records and trial testimony show clear improvement during these periods. But once she was discharged, she was returned to that same condition that precipitated her breakdown: isolation, religious pressure, sleep deprivation, overwhelming responsibility. The doctors were explicit in their warnings. And according to testimony, multiple physicians told Rusty Yates and Andrea, do not leave her alone with the children. She requires constant supervision. That medication compliance was critical. And perhaps most importantly, she should not have any more children. All of those warnings were ignored. In fact, after Andrea showed signs of improvement, her medication was often reduced or discontinued entirely, either due to concerns about the side effects or pressure to return to her functional role as quickly as possible. Trial experts emphasize that abrupt medication changes in patients with psychotic depression significantly increase relapse risk. Andrea relapsed repeatedly. Sleep deprivation also played a critical role. Caring for 5 young children with little support means Andrea was rarely able to sleep for extended periods of time. Sleep loss is a known trigger for psychosis, particularly in postpartum patients. Witnesses testified that Andrea would stay awake late into the night, rigidly completing household tasks, unable to rest. Her illness became increasingly religious in context. She developed fixed beliefs about sin, damnation, and moral failure, believing she was just inherently bad, that her thoughts were evidence of corruption. She was unfit as a mother. These were not abstract fears, though. They were delusions reinforced by her environment and belief system. Psychiatrists testified that Andrea's religious delusions were not a sign of her faith, but of her illness. The content of psychosis often reflects a patient's cultural or spiritual framework. In Andrea's case, her theology provided the vocabulary for her illness. By 2000, Andrea was barely functioning. She stopped bathing, she ate very little, she spoke minimally. Family members described her as vacant, robotic, and disconnected. She would sit for hours staring at walls, at times appearing catatonic. Despite this, though, expectations remained unchanged. She was still responsible for the children, still expecting to manage the home, still told that endurance was her duty. There was no long-term inpatient care, no structured outpatient program, no consistent psychiatric oversight. And during trial proceedings, experts emphasized that Andrea's displayed nearly every known risk factor for postpartum psychosis: history of mood disorder, prior psychotic symptoms, rapid successive pregnancies, abrupt medication changes, severe sleep deprivation, religious delusions, social isolation, and lack of sustained support. In other words, this wasn't unpredictable. It was a textbook case. And yet, interventions remained reactive rather than preventative. Hospitalization occurred only after crisis. Discharge plans lacked enforcement. Warnings were issued without follow-up. Andrea herself repeatedly expressed fear of being alone with her thoughts. She reportedly asked for help, requested supervision, and voiced concerns about the fact that she was struggling to function. These were not subtle signals. They were direct appeals. She was begging for help. Still, responsibility for managing her illness fell largely on her, a woman whose illness impaired her capacity to manage anything at all. One of the most striking elements revealed during trial testimony was how clearly Andrea improved under proper care. When medicated appropriately, when allowed to sleep, when relieved of pressure, she stabilized. And this underscored a devastating truth. Her illness was treatable. It was always treatable. It simply wasn't treated consistently. The narrative that later emerged, that her breakdown was sudden or inexplicable, does not align with her medical records. Her decline unfolded over years in full view of doctors, family members, and institutions that recognized the failure, the danger, but they failed to prevent it. 5 pregnancies did not cause Andrea's illness. They exacerbated it. And each birth layered hormonal shifts onto an already unstable neurochemical foundation. Each postpartum period pushed her further from her baseline. Without recovery time, without sustained treatment, without support, the illness deepened. And by the time she reached the final stage of psychiatric deterioration, she wasn't making rational choices. She was navigating a reality defined by delusion, fear, and unbearable guilt. Her history is not a mystery. It's a documented case study in what happens when a severe treatable psychiatric condition is allowed to progress unchecked, when warnings are issued but never enforced, when care is episodic instead of continuous, and when endurance is mistaken for strength. 5 pregnancies, 1 untreated illness, and a system that failed every opportunity to intervene. The morning of June 20th, 2001 began like many in the Yates household in Houston. Rusty Yates was early and prepared to leave for work. Andrea was already awake. She had been up for hours, as she often was, rigidly following a routine that had become both her coping mechanism and a symptom of her illness. The house was quiet except for the sounds of 5 children moving through the morning. Rusty left home shortly after 9 a.m. This was not supposed to be a long or unsupervised visit. Rusty's mother, Dora Yates, was scheduled to arrive at approximately 10 a.m. to help Andrea with the children, as she had been doing regularly following Andrea's most recent psychiatric hospitalization. Doctors had warned explicitly that she should not be left alone with her children. The plan that morning left a very narrow window, less than an hour, where Andrea would be by herself. That hour changed everything. What happened during that time would be later reconstructed through her own statements to the police, forensic evidence, and expert testimony. There was no chaos, no struggle, no attempts to flee. There was methodical action driven by delusion. Andrea later explained that she believed her children were in grave spiritual danger. She believed that she was a bad mother, that she had corrupted them, and that they would inevitably grow up to be sinful, rebellious, and condemned to hell. These beliefs were not fears or metaphors. They were fixed, psychotic delusions, and in her mind, this was not a crime. It was a solution. One by one, she drowned her 5 children in the bathtub. She moved with deliberation, following a sequence of, she later described, calmly, without visible emotion. There was no evidence of panic. There was no indication that she was responding to voices commanding her to act in that moment. Instead, psychiatric experts would later testify that Andrea was acting under a deeply ingrained belief system shaped by months of psychosis. Afterward, she placed her children on the bed and the floor, arranged them carefully, covered some of them. She left the bathroom and the house in a very orderly state. Then she made 2 phone calls. First was to 911. When the dispatcher answered, Andrea's voice was flat and controlled. She didn't scream. She didn't cry. She said she needed a police officer at her address, and when pressed for more information, she simply said, "I just killed my kids," and hung up. The second call was to Rusty. "It's the children," she said. And Rusty later testified he knew immediately that something was terribly wrong. He asked her, "Which one?" "All of them." Police arrived within minutes. Andrea was waiting just inside the home. She didn't attempt to run, didn't resist. Officers described her as composed, cooperative, and eerily calm. When asked what happened, Andrea stated matter of fact, "I just killed my kids." There was no visible emotional reaction. This absence of affect would later become a point of contention at her trial, misunderstood by many observers as coldness or lack of remorse. Psychiatrists explained that it was consistent with severe psychosis and emotional blunting, a state in which the brain is so overwhelmed that emotional response is flattened or simply inaccessible. Andrea led officers through the house. The children were found exactly where she told them they were. There was no sign of struggle beyond what was inherent to the act itself. The scene was quiet, controlled, and devastating. Andrea was taken into custody without incident. In the hours and days that followed, investigators attempted to understand her motive. She never denied what she'd done. She didn't attempt to justify it in any legal terms. Instead, she explained it through the lens of her delusions. She believed that she had saved her children. Andrea told the police and later mental health evaluators that she believed that her children were not developing morally as they should be. She believed that she had failed God as a mother. She believed that allowing them to live would condemn them to eternal punishment, and in her mind, death was never a harm. It was mercy. This belief did not emerge suddenly that morning. Trial testimony would reveal that Andrea had been preoccupied with these thoughts for months, fixating on religious ideas of sin, purity, and damnation. She believed she was evil, that her thoughts alone were corrupting her children. I'll repeat that. This wasn't something that Andrea had done to her kids to make her think that she had caused them harm. She believed that simply because she sometimes thought negative things, that she had corrupted her kids, and that the longer they lived under her care, the worse their spiritual fate would be. Psychiatrists testified that Andrea's actions were consistent with altruistic filicide, a rare category in which a parent kills a child under the delusional belief that the act is in the child's best interest. This form of filicide is most often associated with severe mental illness, particularly psychotic depression or postpartum psychosis. Andrea's belief that she was saving her children's soul, it wasn't symbolic. This was very literal to her. She believed that heaven was real, she believed that hell was real, and she believed her children were destined for one or the other, and that she was responsible for helping them get there. During psychiatric evaluations, Andrea expressed confusion as to why people were upset. In her mind, she had prevented something far worse than death. She did not initially express remorse in the way that people expected, not because she lacked feeling, but because her reality did not align with everyone else's. The dissonance would later fuel public outrage. Many could not reconcile the calmness of her demeanor with the horror of the actions. But mental health experts testified that Andrea's presentation was classic for someone experiencing severe psychosis. She wasn't processing events through a shared reality. She was operating within a closed belief system that had become impermeable to reason. Importantly, there was no evidence that Andrea acted out of anger, revenge, or hatred. There was no evidence of substance abuse, no evidence of external coercion, no attempt to conceal it. She called the police, called her husband, and she waited. The structure of these actions matter. Andrea acted only during the brief window when she was alone. She stopped when it ended. There was no continuation, no escalation beyond that hour. This was not impulsive violence. It was the culmination of that fixed delusional plan carried out under the belief that it was morally necessary. When Rusty arrived at home, he was prevented from actually speaking to Andrea. He collapsed outside as she was being led away by the police. She never attempted to interact with him further. In the days that followed, the case would shock the nation. Media coverage was swift and unforgiving. Andrea was immediately labeled a monster, a murderer, a symbol of maternal betrayal. The complexity of her mental illness was largely absent from early reporting, replaced by moral outrage and sensationalism. But inside the legal system, a different picture began to emerge. Medical records shows years of documented illness, hospitalizations, suicide attempts, psychotic symptoms, explicit warnings. June 20th, 2001 wasn't an isolated incident. It was the final manifestation of a psychiatric collapse that had been unfolding for decades. Andrea Yates did not wake up that morning as a rational actor making a criminal decision. She woke up as a severely psychotic woman whose grasp on reality had eroded to the point that death was preferable to life. Not for herself, but her children. That distinction would become central to everything that followed. But on that morning, none of it mattered. There was only 1 hour, 5 children, and a mind no longer capable of distinguishing salvation from destruction. Once Andrea was formally charged with capital murder, the system moved quickly to frame this case in the narrowest possible terms. 5 children were dead. Their mother admitted that she was responsible. From the outset, Andrea's decades-long history of mental illness was treated not as the central issue, but an inconvenience that needed to be managed. Under Texas law, capital murder carries the possibility of the death penalty. Prosecutors ultimately declined to seek execution, but the charge itself set the tone. This would be a trial about culpability, not illness. Despite extensive medical records documenting psychosis, suicide attempts, hospitalizations, and explicit warnings from doctors, Andrea's mental health was largely sidelined in the initial framing of this case. Instead, the prosecution focused on a single legal question. Did Andrea Yates know that what she was doing was wrong? See, in Texas, the insanity defense is among the strictest in the country. A defendant is considered legally insane only if, at the time of the offense, they did not understand their actions were wrong. Not immoral, not tragic, but wrong. The prosecution built its case almost entirely around this standard. They argued that Andrea's behavior before and after the killings proved she understood right from wrong. She waited until she was alone. She called the police. She told her husband what she'd done. These actions, these claims demonstrated awareness and intent. Mental illness, they argued, did not absolve her. The defense countered that Andrea's understanding of wrong was profoundly distorted by her psychosis. Yes, she knew that society would condemn her actions, but she believed delusionally that God required them, that failing to act would be the greater wrong, that eternal damnation outweighed earthly law. This distinction mattered. Psychiatrists for the defense testified that Andrea was suffering from postpartum psychosis, a severe mental illness that impaired her ability to distinguish moral reality. Her beliefs were not rational calculations. They were fixed delusions rooted in illness, reinforced by years of untreated psychiatric deterioration. But the jury didn't get to hear the stakes of that distinction. One of the most consequential aspects of this first trial was that jurors were not allowed to know. Under Texas law, juries are explicitly barred from being informed of the consequences of a verdict of not guilty by reason of insanity. They are instructed to decide only whether the legal standard is met, not what happens afterward. This meant that the jury never learned that an insanity verdict would result. This meant that the jury never learned that an insanity verdict would not result in Andrea being released. They didn't hear that she would be committed to a state psychiatric hospital probably for life. They did not hear what she would be suspect to strict oversight, evaluations, and confinement. They did not hear that insanity acquittals often result in longer institutionalization than prison sentences. Instead, many jurors would later admit that they believed an insanity verdict meant Andrea could walk free. That misunderstanding was very important. During deliberation, jurors repeatedly struggled with sympathy for Andrea's illness, but they feared the implication of acquittal. Without accurate information, the legal system allowed a false binary to take hold. Guilty meant accountability, insanity meant danger. The prosecution capitalized on that fear. Their strategy was not to deny that Andrea's mental illness existed, but to minimize its legal relevance. They emphasized moments of apparent lucidity, highlighting her calm demeanor. They framed her actions as calculated more than compelled. And then came the testimony that would ultimately undo this verdict. Dr. Park Dietz, a prominent forensic psychiatrist, testified for the prosecution as an expert witness. Dietz was well known for consulting on high-profile criminal cases and for his work in criminal profiling. His credentials carried significant weight to the jury. And during his testimony, he made a critical claim. He told the jury Andrea Yates had been inspired to kill her children by watching an episode of Law & Order in which a woman drowned her children and was found insane. According to Dietz, Andrea had watched this episode shortly before the killings, suggesting premeditation and imitation rather than psychosis. That implication? It was devastating. If Andrea had modeled her actions after a TV show, then her behavior was conscious, rehearsed, and strategic. It reinforced the prosecution's narrative that she knew exactly what she was doing, and she was just manipulating the insanity defense. There was only one problem. That episode didn't exist. There had never been an episode of Law & Order that matched Dietz's description before June 2001. This claim was factually false, and at the time of the trial, no one even challenged it. The defense did not immediately catch the error. The prosecution didn't correct it. The jury accepted the testimony as credible and authoritative. Dietz's statement became a turning point in the trial. Jurors would later cite it as influential in their decision-making. It offered a simple explanation that cut through the complexity of her mental illness. She wasn't delusional. She was just inspired. In 2002, after deliberating, the jury found Andrea Yates guilty of capital murder. She was sentenced to life in prison. The verdict was met with public approval. Media coverage framed the outcome as justice served. Andrea was portrayed as a calculating killer who had evaded responsibility for far too long. The nuance of her psychiatric history was lost in the finality of the conviction. But this case was not over. See, in the years following the trial, defense attorneys uncovered the truth about Dietz's testimony. Independent review confirmed that Law & Order episode, it never aired. Dietz later admitted his mistake, stating that he had confused the show with another fictional program. But that error was not minor. It went directly to Andrea's state of mind, the central issue of this trial. In 2005, the Texas Court of Appeals overturned Andrea Yates' conviction. The court ruled that Deet's false testimony was materially prejudicial and that the jury had relied on inaccurate information in reaching its verdict. The appellate court's decision was unequivocal. Andrea had not received a fair trial. The ruling sent shockwaves to the legal and mental health community. It forced a reckoning with how the justice system handles defendants with severe mental illness, particularly women, and particularly mothers. The first trial had failed not because the law was unclear, because it was misapplied. Andrea's mental illness was real. Her psychosis was documented. The risk factors were known. And yet the jury had been asked to decide her fate without critical information, misled by expert testimony that should have never been allowed to stand. 3 years after she was sentenced to life in prison, Andrea Yates' conviction was vacated. The trial that had defined her as a criminal was officially acknowledged as flawed. What followed looked very different. When Andrea Yates was retried in 2006, the courtroom atmosphere was markedly different from the one that defined her first trial 4 years prior. The facts of the case had not changed. The outcome of June 20th, 2001 was no different. What changed was the willingness of the legal system to confront Andrea Yates' mental illness honestly and to let a jury fully understand what it meant this time. By the time the second trial began, the failures of the first had been publicly acknowledged. The appellate court's decision to overturn the conviction made it clear that Andrea had not received a fair trial, largely due to that false expert testimony and the minimization of her psychiatric history. This time, both sides approached the case knowing that scrutiny would be intense. From the outset, the defense centered the trial on medical evidence. Jurors were presented with years of documented psychiatric records, hospitalizations, diagnoses, medication histories, suicide attempts, and repeated warnings from her doctors. They heard directly from psychiatrists who had treated Andrea before and after the death of her children. Not consultants speculating after the fact, but the clinicians who had observed her illness while it was unfolding. The defense did not argue that Andrea lacked awareness. Instead, they argued that her understanding of reality was profoundly distorted. Psychiatrists explained postpartum psychosis in clear, clinical terms, describing it as a rare but severe psychiatric condition marked by hallucinations, delusions, disorganized thinking, impaired judgment, often emerging suddenly after childbirth in women with prior disorders. Importantly, they explain that postpartum psychosis can exist with seemingly logical behavior. A person may appear calm, organized, or purposeful while operating under completely false beliefs. This addressed one of the prosecution's strongest arguments from the first trial, that Andrea's orderly actions proved that she was sane. This time, jurors learned that psychosis does not always look chaotic. See, doctors testified that Andrea's illness had been mismanaged for years. Each pregnancy increased her vulnerability, medication was stopped or reduced despite clear warning signs, and that sleep deprivation alone can trigger relapse. One psychiatrist described Andrea's condition as one of the most severe cases of postpartum psychosis I have ever seen. Another testified that Andrea was incapable of rational moral judgment at the time of the events. The prosecution shifted its approach this time. Rather than aggressively disputing Andrea's diagnosis, prosecutors acknowledged her mental illness, but questioned whether it met the legal standard for insanity. They argued that Andrea still understood that society would view her actions as wrong. But the defense dismantled that argument by reframing what wrong actually meant to Andrea. Jurors heard that Andrea believed God required her actions, that she believed Jurors heard how Andrea believed God required her action, that she believed eternal salvation outweighed earthly law, that failing to act would result in her children's damnation, a far worse outcome in her delusional mind. Psychiatrists emphasized that Andrea's belief system left no room for alternatives. This was more than just a choice between good and bad. In her mind, it was a choice between saving her children or condemning them to hell. The jury also heard testimony about failure surrounding Andrea. The doctors who had treated her testified that they had warned that she should never be left alone with the children, that she should not have any more children, that her illness required constant supervision and strict medication adherence. Jurors were shown how time and time again those warnings were ignored. This contextualized Andrea's actions, not as an isolated decision, but as the final outcome of systemic neglect. And crucially, the second jury wasn't misled. There was no false testimony, no speculation of pop culture explanations, no suggestion that she had been inspired by fiction. Instead, jurors were asked to grapple with medical reality. And for the first time, the courtroom allowed a full discussion of what not guilty by reason of insanity actually meant. While Texas law still restricts explicit discussion of post verdict consequences, expert witnesses and legal framing made clear that Andrea was not seeking freedom here. She was seeking acknowledgement that she was not operating within reality at the time of her offense. The jury deliberated carefully. When the verdict was read in July of 2006, Andrea Yates was found not guilty by reason of insanity. The decision was not met with universal approval, though. Public reaction was divided, with some expressing outrage, others expressing relief that the legal system had finally recognized the role of this severe mental illness. But legally and medically, the verdict was sound. Andrea Yates was immediately committed to a state psychiatric hospital. This was not a symbolic commitment either. Under Texas law, individuals found guilty by reason of insanity are confined to a secure mental health facility and they remain under state supervision. Release is not automatic or set based on time. It is contingent on. Ah, dang. I ran out of juice. There we go. Under Texas law, individuals found not guilty by reason of insanity are confined to a secure mental health facility and remain under state supervision. Release is not automatic or based on simply a number. It's contingent on repeated evaluations and judicial approval, plus demonstrated stability. In many cases, confinement lasts much longer than a prison sentence ever would have. And Andrea remains institutionalized even today. The second trial did not erase the tragedy. It didn't lessen the loss. It didn't undo the harm. But it did correct the narrative. Andrea Yates was not a calculating criminal exploiting a legal loophole. She was a severely mentally ill woman whose untreated condition culminated in an irreversible catastrophe. The second verdict acknowledged something the first could not: that justice is not served by pretending that illness does not exist. That accountability and compassion are not mutually exclusive. That understanding is not the same as excusing. The truth of the case did not change between 2002 and 2006. The willingness to face it did. And the years since Andrea's case has faded from daily headlines. It has quietly taken on a second life. Not in the tabloids, not in the courtrooms, but in medical schools, psychiatric journals, maternal health advocacy circles, and legal ethics discussions. By the mid-2010s, Andrea Yates was no longer treated as simply a sensational crime story. She became a case study, one that exposed the catastrophic consequences of untreated postpartum psychosis, fragmented mental health care, and a justice system ill-equipped to distinguish illness from intent. In that sense, something had changed. Postpartum psychosis is no longer an obscure diagnosis known only to specialists. Today, it is widely recognized within psychiatry as a medical emergency, a condition requiring immense hospitalization, medication, sleep stabilization, and long-term follow-up care. Clinical guidelines now emphasize that postpartum psychosis is not an extension of postpartum depression, but a distinct and far more dangerous disorder. This recognition is not abstract. Medical students now routinely study cases just like Andrea Yates as examples of what happens when warning signs are ignored. Psychiatry residents are taught that postpartum psychosis can present with calm affect, organized behavior, and religious moral delusions. Features that once led clinicians, jurors, and the public to misinterpret illness as calculation. There has also been progress in screening. Many hospitals now conduct postpartum mental health screenings beyond the traditional baby blues questionnaire. Some states have implemented mandatory education for obstetric providers on recognizing psychosis. Professional organizations such as the American College of Obstetrics and Gynecologists now explicitly identify postpartum psychosis as a condition requiring emergency intervention. But these improvements are uneven. See, screening protocols vary widely by state, hospital system, and insurance coverage. In some settings, screenings end after 6 weeks postpartum, despite the fact that postpartum psychosis can emerge months after delivery. In others, screening exists on paper but lack meaningful follow up pathways. Recognition without access isn't prevention, and access remains the most persistent failure to this day. Insurance limitations on inpatient psychiatric care continue to be one of the largest barriers facing postpartum women in crisis. Even today, many insurance plans severely restrict the length of psychiatric hospitalization, prioritizing rapid discharge over stabilization. Mothers experience psychosis. They're often released once they're no longer acutely suicidal, even if those delusions, hallucinations, and impaired judgment still exist. That was one of the central failures in Andrea Yates' care. She repeatedly stabilized in hospitals only to be discharged back into her collapse. The pattern has not disappeared since. Advocacy organizations continue to document cases where postpartum women are denied expended inpatient care because they are deemed not an imminent threat, despite clear psychotic symptoms. There's also a glaring shortage of specialized mother baby psychiatric units in the United States. In other countries, these units allow mothers to receive treatment without being separated from their children, a model shown to improve outcomes and actually reduce the stigma. In the US, such units are very rare. As a result, women in psychosis are often forced into one of two options: untreated suffering at home or separation from their children in facilities that are not equipped for postpartum care. Both outcomes can make this illness worse. Perhaps the most troubling continuity from Andrea Yates' era to present day is this: women with postpartum psychosis are still more likely to be incarcerated than treated. When postpartum psychosis goes unrecognized, its consequences often manifest as behavior that draw law enforcement rather than clinicians. Mothers get arrested for neglect, endangerment, and worse. Their illness is reframed as criminality. Once inside the legal system, the same misunderstandings that plagued Andrea's first trial persist. Calm demeanor is misread as a lack of remorse. Religious delusions are misread as simply beliefs rather than psychosis. Orderly actions are misread as planning rather than a compulsion. Insanity defenses remain rare, heavily stigmatized, and poorly understood by the public. Jurors still fear that an insanity verdict means you're letting the criminal get away, despite decades of evidence to the contrary. Andrea Yates remains one of the most cited examples used to counter this fear. More than 2 decades after her retrial, she remains confined at Kerrville State Hospital in Texas, a maximum security psychiatric facility. She has reverted to using her birth name, Andrea Kennedy, a choice that reflects both distance from her married identity and the profound reshaping of her life after being institutionalized. According to available reports, Andrea participates in therapy, medication management, and art therapy. Her daily life is very structured. Every aspect of her care is monitored. Any possibility of conditional release would require extensive psychiatric evaluation and court approval, a threshold that has yet to be met. Contrary to popular misconception, Andrea has not sought release. Those familiar with the case know that she has expressed remorse, grief, and sorrow once she was stabilized, emotions that were inaccessible during her active psychosis. Her confinement is not symbolic, it is indefinite. In practical terms, Andrea Yates will probably spend the rest of her life in an institution. Rusty Yates divorced Andrea in 2004 before the first conviction was overturned. He has since remarried and divorced again. In later interviews, Rusty has acknowledged, often obliquely, that the system failed his wife. He has spoken about lack of resources, poor guidance, and inadequate support, but many critics argue that that framing is incomplete. The doctors warned him. The warnings were repeated. They were documented. The state explicitly said Andrea should not be left alone. She should not stop her medication, and you too should stop having children. Those warnings were not an abstract failure of the system. They were concrete, specific, and urgent. And Rusty, you ignored it. This is where the legacy of Andrea Yates becomes uncomfortable, because it forces a reckoning that not just with institutional gaps, but with personal accountability within those gaps, with how religious ideology can override medical advice, with how cultural expectations of motherhood demand endurance at the expense of safety, with how women's suffering is moralized rather than treating. In the last decade, public conversation around maternal mental health has expanded dramatically. Campaigns encourage mothers to speak up. Celebrities have disclosed their own postpartum struggles. Awareness hashtags circulate widely, and yet awareness has not translated into infrastructure. Women still report being dismissed when they describe intrusive thoughts, still fear losing their children if they disclose they're having hallucinations, still face clinicians who mistake psychosis for simply stress. Andrea's case remains a warning, not because it was unique, but because it was preventable. It shows what happens when warning signs are interpreted as character flaws, when religious certainty outweighs medical expertise, when responsibility is placed on someone whose illness has stripped them of the ability to bear it. In the end, the most honest assessment is the most difficult. The system failed, the doctors warned, and safeguards existed in theory. But her children paid the ultimate price. And what has changed since Andrea Yates is that now we know better. What has not changed is whether we consistently act on that knowledge before tragedy makes the lesson unavoidable again. I'm Brittany Ransom, and this has been When Killers Get Caught. Andrea Yates was not a monster. She was a woman with severe, treatable psychiatric illness, one that was documented, diagnosed, and repeatedly warned about. She was hospitalized, stabilized, and then sent back to the same conditions that were breaking her. Taken off medication, isolated, told to endure. And when she showed signs of psychosis, her suffering was framed as a spiritual failure instead of what it really was, a medical emergency. We like to believe that cases like this are relics of the past, that we've learned, that we screen better, that we intervene sooner. But the uncomfortable truth is this: if this happened today, there is absolutely no guarantee the outcome would be any different. Postpartum psychosis is still very misunderstood. Inpatient psychiatric care is still very limited. Mothers are still afraid to speak honestly, and women in crisis are more likely to encounter the police than a clinician. Andrea Yates' story forces us to confront something that we don't like to admit: that tragedy doesn't always arrive suddenly. Sometimes it unfolds slowly, in plain sight, documented in medical charts, echoed in warnings that go unheeded. Because the truth doesn't disappear when we ignore it. It leaves records, it leaves patterns, it leaves consequences. And eventually, the truth always leaves a trail. Thank you for listening.